Tidal volume in neonates averages 4 to 6 milliliters per kilogram, representing the air moved with each normal breath. Residual volume is the gas that remains in the lungs even after maximal exhalation, preventing alveolar collapse. Lung capacities are combinations of these basic volumes. Functional residual capacity, formed from residual volume plus expiratory reserve volume, is the volume left at the end of passive expiration. It is critical for alveolar stability because it maintains surface area for gas exchange between breaths. Total lung capacity is the maximum gas volume the lungs can hold, equal to the sum of all volumes. For neonatal care, these definitions frame how much reserve is available for oxygenation and how vulnerable the infant is to collapse when volumes are small. Neonates actively maintain functional residual capacity despite their compliant chest wall and small tidal volumes. One strategy is expiratory braking, achieved by partial laryngeal closure or grunting, which slows exhalation and preserves lung volume. Sustained inspiratory muscle activity at the end of expiration provides another mechanism to prevent alveolar collapse. A high respiratory rate shortens expiratory time, limiting how much volume can be lost before the next breath. When these mechanisms fail, functional residual capacity decreases, leading to atelectasis, hypoxemia, and reduced compliance. Clinically, continuous positive airway pressure mimics these physiologic strategies by keeping alveoli open and stabilizing lung volume, which is why it is so effective in preterm infants with unstable lungs. Lung compliance describes the change in volume per unit of pressure. In neonates, compliance is low because immature connective tissue and limited surfactant make the lungs stiffer. Chest wall compliance, in contrast, is extremely high. The ribcage collapses inward with little resistance, especially during inspiration, which undermines the ability to maintain stable lung volumes. When lung and chest wall properties are combined, the result is an unstable functional residual capacity and inefficient ventilation. This balance explains why neonates are prone to rapid desaturation. The lungs require high pressure to inflate, while the chest wall easily collapses and removes the volume that was gained. Surfactant deficiency exaggerates the already low compliance of neonatal lungs, making inflation especially difficult in preterm infants. Administration of exogenous surfactant rapidly improves compliance by reducing surface tension and stabilizing alveoli. Continuous positive airway pressure supports alveolar stability and counteracts the collapsing tendency of the compliant chest wall. However, when chest wall compliance is excessive, as in very premature infants, it may cause paradoxical inward movement during inspiration. This paradox reduces efficiency and increases the work of breathing. Understanding these dynamics guides therapy. Target surfactant to improve lung mechanics and use CPAP to balance chest wall forces and preserve functional residual capacity. Airway resistance is strongly influenced by airway diameter. According to Poiseuille's law, resistance is inversely proportional to the radius raised to the fourth power, so even a small narrowing produces a large increase in resistance. Flow dynamics also matter. At low flow rates, air moves in a laminar pattern with less resistance, while higher flow rates generate turbulence that markedly increases resistance. For neonates, the already narrow airway caliber magnifies these effects, creating a disproportionate rise in resistance and work of breathing with even minor edema, secretions, or malacia. This sensitivity explains why airway stability and patency are central to neonatal respiratory management. In neonates, the nasal passages account for about half of the total airway resistance. Because they are obligate nasal breathers, maintaining nasal patency is essential for effective ventilation. Even minor obstruction from edema, secretions, or structural weakness like malacia can significantly raise resistance and increase the work of breathing. Clinical conditions such as choanal atresia or even simple nasal congestion quickly compromise airflow. The same principle applies to respiratory support. If nasal prongs from CPAP do not fit properly, resistance rises and support becomes ineffective. These features highlight why attention to the nose and upper airway is uniquely important in neonatal care compared with older children or adults. Work of breathing reflects the energy required to overcome two forces: the elastic recoil of the lungs and chest wall, and the resistance of the airways. In neonates, all of these components make breathing less efficient. Low lung compliance means the lungs are stiff and require more pressure to inflate. At the same time, the chest wall is highly compliant, collapsing inward during inspiration and wasting energy. The narrow caliber of the neonatal airway further increases resistance, amplifying the pressure needed to move air. The combined effect is that respiratory effort rises quickly, and distress can overwhelm the infant's limited capacity. When fatigued, neonates transition to hypoventilation and apnea, which underscores how narrow the margin is between compensation and failure. A time constant is defined as compliance multiplied by resistance, and it predicts how quickly a lung unit fills or empties. One time constant equals the time needed for about 63% of the change in volume. 3 time constants achieve roughly 95%, and 5 reach near complete filling or emptying. In neonates, short time constants dominate because their lungs are stiff and airways are small, so units fill and empty quickly. In conditions like bronchopulmonary dysplasia or airway obstruction, compliance or resistance increases, producing long time constants with delayed emptying and air trapping. On the ventilator, these principles guide inspiratory and expiratory times. Too little time for inspiration limits alveolar filling, while too little time for exhalation traps gas and worsens ventilation. Not every lung region has the same time constant. Some units are short, filling and emptying quickly, while others are long, changing much more slowly. The curves shown on this slide make the contrast clear. Fast units inflate steeply and collapse just as rapidly, while slow units rise and fall gradually. This variability produces uneven ventilation, a major source of ventilation perfusion mismatch. If exhalation is prolonged, the fast units may completely empty and collapse. If exhalation is cut short, the slow units retain gas and develop air trapping. Clinically, tailoring inspiratory and expiratory times is essential to balance both extremes, reducing collapse in short time constant regions while avoiding overdistension in long time constant regions. Efficient gas exchange requires balance between alveolar ventilation, or V, and pulmonary blood flow, or Q. A mismatch between the two is the most common cause of hypoxemia in neonatal lung disease. Low V/Q occurs when perfusion exceeds ventilation, as seen with atelectasis, respiratory distress syndrome, or pneumonia, where alveoli are perfused but poorly ventilated. High V/Q occurs when ventilation exceeds perfusion, such as with air leaks or airway obstruction, where alveoli are ventilated but not adequately perfused. Recognizing whether hypoxemia is driven by low or high V over Q is critical because it directs management, restoring lung volume and ventilation in the former, or addressing obstruction and perfusion in the latter. Gas exchange across the alveolar capillary membrane is determined by surface area, membrane thickness, and capillary proximity. Oxygen moves from alveolus to capillary, but diffusion is limited when surface area is small, as in premature infants, or when membranes are thickened by disease. Carbon dioxide diffuses more readily, so clearance is usually preserved until gas exchange is severely compromised. Neonates are especially vulnerable because their oxygen consumption is high, about 6 to 8 milliliters per kilogram per minute, leaving little reserve. This explains why even brief hypoventilation, or V/Q mismatch, causes rapid desaturation. By linking oxygen diffusion capacity with the V/Q principles of the prior slide, we see why maintaining alveolar surface area and adequate matching of ventilation to perfusion is central to preventing hypoxemia in this population. The key physiologic concepts come together in clinical practice. Loss of functional residual capacity causes rapid desaturation. Continuous positive airway pressure restores volume and stabilizes alveoli. Poor compliance, often from surfactant deficiency, requires surfactant therapy and higher pressures to open the lungs. High resistance emphasizes the importance of maintaining nasal patency and selecting appropriately sized endotracheal tubes. Ventilation perfusion mismatch is the dominant mechanism of hypoxemia in neonatal lung disease, linking back to both alveolar surface area and regional time constant variability. Time constants guide ventilator strategy. Restrictive lungs with short constants need rapid rates and shorter inspiratory times, while obstructive physiology with long constants requires longer exhalation to prevent trapping. When combined, these principles explain why interventions like CPAP, surfactant, Careful airway management and ventilator adjustments are not isolated maneuvers but targeted responses to the physiology of the newborn lung.